Hello and welcome to this new podcast of the American Journal of Public Health. Today, we will be talking about a very important issue that has some incredible historic roots, the issue of indoor air pollution. And this can be home, this can be occupation, this can be a different environment. How long has public health been interested in those issues? What we went through the COVID-19 pandemic. There were lots of issues related to indoor air quality and contaminations. And what did we learn? And why are we better ready today after that pandemic than we were before? These are the questions that we are going to discuss with our guests. So let's start with John Samet. Hello, John.
Hello, Alfredo, and hello, everybody. I'm John Samet at the Colorado School of Public Health and have worked on issues related to indoor and outdoor air quality for a long time.
Thank you, John. And then we have David Michaels.
Hello, Alfredo. It's great to be with all of you today. I'm a professor at the George Washington University School of Public Health in Washington, D.C. During the Obama administration, I ran the Occupational Safety and Health Administration.
Thank you, David. And then we have Paul Sampson, historian here in our group. So Paul, welcome.
Thank you, Alfredo. Thank you for having me on. It's wonderful to be here with you and with Jonathan and David as well. And I'm a historian of science and medicine, and I currently teach at the University of Scranton in Pennsylvania. I'm working on a long history of ventilation from the 18th century up until the mid-19th century.
Thank you. But that's interesting. And actually, that brings us directly into our conversation because you're thinking about 18th century and later. But when you think of it, as soon as there is some medical thinking on the planet, immediately people have been associating pandemics or epidemics with air pollution. This miasma theory, you find it in China, you find it in Mesoamerica, you find it in Europe, of course, everywhere. So people in some way were obsessed with air pollution. So why does your history start in 18th century?
Well, you're exactly right, Alfredo. I mean, the obsession with air pollution, at least in the West, goes all the way back to Galen and the non-naturals, and even further back into the ancient Greek medicine of Hippocrates. But I begin in the 18th century because I ran across a really strange device, a ventilator trunk, that was proposed by a British cleric and scientist, natural philosopher in the early 18th century. And I found a spat of all these different strange devices being designed to mitigate air pollution, especially in enclosed spaces. And I wondered, why in the 18th century did natural philosophers and physicians start to become really interested in these strange devices to mitigate air pollution when, of course, we've known that disease is associated with bad air for 1,000 years at that point. So that's where my history really began and my interest in the topic began.
Yeah, but they were associating disease with air even when it was not in the air. The miasma and cholera was wrong. And it was, they thought that air pollution caused cholera. So it was really the main hypothesis in terms of disease causation.
Yeah, you're exactly right. It was. So, I mean, what I argue is that air has always been an object of fascination, but as they started doing more and more mechanical studies of respiration, human respiration, they started to wonder if there was a way to improve air mechanically with these machines and these new ways of ventilating enclosed spaces. And what I argue is that even though it became clear later on, just as you say, that cholera and other diseases are caused by non-aerial factors, non-aerial vectors, these machines became part of the infrastructure of many modern buildings just because people felt safer and more comfortable with these machines in their homes. So it became more about comfort and less about disease prevention, because clearly, a ventilator is not going to prevent you from getting cholera or, dysentery or any of these other kind of awful diseases.
Yeah, I might put a little more contemporary spin on it and say that across the last century, the American Society originally of Heating, Ventilating Engineers, and then the American Society of Heating, Ventilating, Refrigerating, and Air Conditioning Engineers, or ASHRAE, had a key role. And I think one thing that happened is the health community itself was quite separate from this group of mechanical engineers who were designing code standards for ventilation for acceptable indoor air quality. And I think in my mind, it wasn't really until somewhere around the 70s when public health community really began to take a strong interest in indoor air pollution and its consequences, that you see this connection and the realization that ventilation had something to do with health, and of course accentuated by COVID-19, the transmission of SARS-CoV-2.
But Jay, when you say 1970s, you mean OSHA?
Well, it's interesting though that you raise OSHA because it's another example of the stovepiping of our public health institutions. I mean, ASHRAE was working on one set of rules. Also in really 1970s and really the second half of the 20th century, the industrial hygiene profession recognized that the best way to control indoor hazards in workplaces, and they were really thinking about industrial workplaces more than offices and things like that, was through the hierarchy of controls, which requires first to eliminate the exposure if you can. And of course, with COVID, that means encouraging people to stay home so they don't bring the virus into the workplace. But in general, moving to safer chemicals, whatever it is. But if you've got a hazard in the workplace air, engineering controls, and particularly ventilation, is the way to address it. But all of the ventilation issues that OSHA and the industrial hygiene community looked at tended to be hazard specific rather than thinking about indoor air in general and how to make the air safe for around all hazards for all people.
OSHA did propose a standard for indoor air in 1994 that was, as you know, buried essentially by the tobacco industry and others.
Correct. I mean, Jonathan's work on that issue was vitally important. And OSHA proposed an indoor air quality standard, but it was really for tobacco smoke, recognizing that indoor air exposure to tobacco smoke increased risk of several diseases. And the tobacco industry mobilized an incredible campaign, including getting, I think, close to 500,000 letters and postcards inundating OSHA saying, don't do this. And OSHA backed way off because they couldn't stand the political pressure.
So that was part of the conversation about exposure to passive smoke, environmental tobacco smoke. That was where the conversation took place, yeah. And so Paul, where does ETS stay, environmental tobacco smoke in your history?
Well, it's interesting because I think the perception of what constitutes clean air evolves quite a bit over time. So in the early 19th century, for example, there was a lot of kind of increasing amounts of coal smoke in the air, especially in places like London, they're industrializing really quickly. And that was actually perceived as cleansing in some ways or healthful. It has this kind of acrid acid quality to it. So they perceive that as a sign of progress and not necessarily dangerous. But as you mentioned earlier, things like miasma that are kind of rotting organic smells were perceived as really dangerous. So that evolves, of course, over time. By the end of the 19th and early 20th century, as I'm sure Jonathan and David know much more than I do, it becomes very clear that a lot of particulates in the air is really dangerous for human health. And so it, like I say, it kind of begins to evolve. And you have more and more kind of calls for clean air, which I think culminates, finally in the 1960s with the Clean Air Act. It's an ongoing story. I mean, I think it's continuing to evolve.
It's the paradoxes here are very interesting because Jon Snow actually was hired by the industry in litigations when the communities were complaining that all this dust from the chimneys were polluting their neighborhoods and they were creating disease. He went, to claim that no, there was no way a disease could be transmitted by the air. It was all, and he was an expert in anesthesia. He knew about gases. So, but now we have the revenge of the miasma with the ETS.
So I just want to close out the secondhand smoke story because I did chair a committee for ASHRAE that said that there could not be acceptable indoor air quality if there was smoking inside. And this position was endorsed by the ASHRAE board. It's been reconfirmed. So I think that set that story of secondhand smoke and acceptable indoor air quality. I think that ended the story. You can't have smoking and acceptable indoor air quality, no matter how much you ventilate.
So that's the historical, turning point. And now we get to the issue of indoor air quality and infectious disease. I know that, David, you worked a lot on preparing some standards about this, and they were ready. And what happened with that?
During the H1N1 pandemic, it became very clear to OSHA that the same thing was needed for airborne pathogens. CDC's suggestion that people wear surgical masks was not going to be effective. And OSHA actually started that process. And when I was there, we made some progress on the standard. And we had expected to issue a proposed standard in October 2017. That was on the federal regulatory agenda with that date. Unfortunately, in January of 2017, a new administration came in, and all work was stopped on that standard, and it was essentially deep sixed. And so when the COVID pandemic hit in March of 2020, OSHA was unprepared. They hadn't made much progress. They'd really stopped working on that. The inspectors were unprepared to go out because they were unprotected. But the main thing is the Trump administration essentially said, we don't need a new standard. OSHA's general duty clause tells employers what to do, which really is nonsense. And as a result of that, workplaces across the country were inundated with COVID cases. And really, it was tragic. I mean, the people with power in the United States, lawyers, CEOs, anybody who could work from home, people like us, could do that. But the workers in essential industries who had to make sure food was on the table and our sick and elderly were being taken care of, they had to go into work every day. And we had no requirements for them for their employer to make their workplaces safe. So OSHA began that process again with the new administration, with the Biden administration, and then essentially it hit another traditional OSHA roadblock, which is industry is very strong and they don't like to see OSHA standards. They viscerally oppose it. And OSHA was ready with a standard in April and May of 2020. And if we go back and look at that, that was a funny time in the COVID pandemic because the vaccination program had really gone full speed. Many people were being vaccinated. We thought at the time that vaccinations would decrease transmission dramatically. We now know that what vaccinations do is they stop disease severity, but people still get sick. And the White House decided that to deep six that proposal. And so it was never released, even as a proposal. OSHA did issue a temporary standard for healthcare workers, and that did require some immediate controls, N95s, a few other things, but really didn't go as far as really necessary to tell employers, look, you've got to deal with this pandemic, prepare for the next one by building in air quality improvement. And there are obvious ways to do that. Better ventilation, filtration, if you don't have pure ventilation, and germicidal disinfection, whatever will work, but you have to do something. But right now we have no requirements for most workplaces to do anything like that.
So David, the standard didn't go through and they're still not accepted. I mean, John, is there any way from your experience with the tobacco smoke that you could give some advices on how to have this standard accepted so that there we do some real progress too?
Well, I think David is the expert. You heard his frustration. I think, and then of course there was a Supreme Court decision that figured in as well with the efforts of OSHA. So, common sense just doesn't seem to be prevailing here, does it? And I think the real concern is there is a lesson learned here, but nobody seems to want to learn it and do something. And I will say, David and I were on a committee of the National Academies that was asked to develop frameworks for providing respiratory protection for the many workers who are not covered and the general population. And as Dave and I have seen, that report released little bit over 2 years ago now. It's just had no traction. And I think COVID fatigue and whatever else are critical roadblocks. This is a time when we should be thinking prospectively. I think that is happening around looking at ventilation in schools, for example. I think there is, I think there are some lessons learned that are having impact, but certainly not around respiratory protection.
But John, if I recall well, the issue of the airline attendants having cancer was key when the decision about passive exposure to tobacco smoke, was ruled, and the agreement was reached with the industry. So there's no accountability for all the deaths that occurs on the workplace because of contamination and of infectious disease. Nobody is accountable for that.
I'm going to bounce that one right to David.
I wish there were. What's challenging is even in situations where large numbers of workers got infected clearly from workplace exposures, because we've done genomic testing, workers have a great deal of difficulty getting workers' compensation payments for those illnesses. It really depends very much on the state. Employers have no great incentive to put in those protections because the workers' compensation system protects them from being sued. There isn't like a deep pocket like the tobacco industry, which really was, on the hook around cigarette smoking. Also, COVID has become so politicized that it's been very difficult to take this on. And I think it's a class issue also. I mean, if all of us who have power in the United States had to go to work every day during that pandemic, and the offices, not just of Tyson's Food, but of Chase Manhattan Bank, people were worried about being exposed to COVID, we would see clamor for much better rules around ventilation. And unfortunately, I think we're seeing that now around heat. That there a lot of workers have to be outside every day in severe heat, but people with power in the United States can stay in air-conditioned rooms and do their work. And so there isn't this uproar, this clamor saying we've got to do something about this.
Paul, from your perspective, do you see this tension between environmental exposure and infectious diseases when we talk about air quality? I mean, is there some trends or patterns historically that you could report?
Well, I just want to, if you don't mind, I'd like to just kind of second some of what David said, that, when these regulations work, and I think the bloodborne pathogens is a great example of this, when they work, they kind of fade into the background and they become part of the natural kind of way of living that we all experience. And we all say, of course, you wouldn't go to the dentist who wasn't wearing gloves. That's completely unacceptable. And I think just from my experience and from my own research, I've seen that these public health decisions are always political decisions. And this is a point that I tried to make in the piece I wrote for AJPH with Elaine Lefay, who's another excellent, public health historian. We just tried to argue that decisions of whether to focus on air quality are always decisions based on what is perceived as, what can you sell basically to the business community? What can you sell to the public politically? And you mentioned this earlier, in the 19th century when sanitarian revolution was happening and sewer systems were being installed everywhere and there was an emphasis on clean public water, they made a deliberate decision. A lot of the sanitarians made a deliberate decision to focus on water and to not trouble with air and air pollution, because that's something that was seen as, too difficult to address. Leave it up to the free market, maybe have some regulation about the number of windows that buildings have to have or things like that. But that does nothing about external environmental air pollution, as you mentioned. So there's many different facets to these issues. And I think that, some of what I guess I can just really echo David's frustration and Jonathan's frustration that, the answer is going to have to come through some strict regulations that are going to make sense, that'll be functional. And you can't just rely on basically voluntary contributions from the business community and things like that.
Got it. I mean, in the last minutes we have in this podcast, I would like to move to another aspect of indoor air quality. We've talked about, corporations and industries, etc., and how we address this problem at the population level. But how can the individual, understand how to protect themselves from any form of air pollution. There was a lot of confusion at the beginning of the COVID pandemic. Do we know today a little bit more how to communicate and what's the message to the individuals when they are, you know, air pollution risk or air quality risk? What should they do?
So I'll comment. I mean, of course, for outdoor air, we have EPA's AQI, Air Quality Index, and warning, and it comes with the weather. And that's basically about how the levels of air pollution outside relate to our national ambient air quality standards. And, I think there's a lot more to be learned there about how to communicate. I mean, in Denver, with our ozone problems, we're sort of in the unhealthy range much of the summer, but we don't have something comparable to for indoor air per se. So carbon dioxide was used as a general indicator of sort of the level of ventilation. Was there enough in relationship to occupancy? And that's one of the tools we have. There's a lot of work going on sensing and developing sensors for these infectious bioaerosols. And I think the dilemma that will come when we have that kind of information in hand is, what does it mean? And what does it mean for risk? And if we know that SARS-CoV-2 is present, maybe just telling this is an epidemic going on or it's surging, and then relating that to risks is something we're going to have to learn how to do. And there are initiatives underway now to do just this. But I think it's fair to say, and Paul is probably the right person to comment, essentially for about a century since the work of Wells and Riley, not much progress was made on dealing with infection through respiratory airborne pathogens. I mean, that's would be my indictment, but Paul, I think
my impression is similar to yours. I mean, I think that there's been again, this is an impression, and you and David would be more qualified to comment, but there seems to have been sort of a throwing up of hands when it comes to respiratory diseases or diseases passed through airborne pathogens, that it's just chaotic, it's hard to control. There's certain things you can do to try to mitigate it, but really, there's nothing really substantial you can do.
This is the classic public health hazard challenge, in that individuals can't control their environment to the extent they'd like to. They don't know what's in the food, what's in the shampoo they buy, and certainly you can learn more about what's in your outdoor air, but there's not much you can do about it. In terms of thinking about what individuals can do with indoor air, I think there are some steps. I mean, obviously, carbon dioxide monitors are useful, and that's a nice thing. But one thought is to have local ordinances, or just individuals who reach out to their building operators and owners to post information about the ventilation and filtration capabilities and activities of their building. And that sort of disclosure, we know from behavioral sciences, has an impact on behavior. Building owners who find out and have to post that their ventilation system isn't doing much will do something to improve it. And so that's sort of beginning to build a movement around this. And I think that's the movement we have to see, that people demanding clean air in their homes, in their workplaces, in their public buildings, in their schools, etc.
Well, I was just going to say, following up on what David said, one locus that has probably received the most attention is schools. Right. And there we've learned that, in fact, many schools don't have adequate ventilation. We've also learned that we don't know much about ventilation in schools. We don't really have data. I think there's a couple 100,000 public schools across the country, and many of them are quite old, and we know we need to work on the ventilation of the schools. There's certainly work going on, but much more to be done at a critical location.
Listen, I want to let you go, but I have the feeling that it's a little bit of a pessimistic podcast. I cannot let you go with at least some positive notes, some silver lining. I mean, what's coming that we can give us hope that this thing is going to get better? And I propose this is going to be your last word. And let's start with the historian.
I guess I will say there's never been more funding available to improve air quality in schools. I mean, that was one thing that I learned in the course of my research for the AJPH piece, is that, the Biden administration, while they didn't provide clear regulation, they did provide an enormous amount of funding for improving infrastructure in schools. So I think that is a hugely positive step, and I think we can be thankful for that.
Well, when we go back to tobacco, it was the research on the effects of secondhand smoke, or environmental tobacco smoke, on non-smokers that really drove a lot of these policy decisions. That increased risk of lung cancer among the spouses of smokers led to a lot of this. And I think we're seeing studies of indoor air quality impacting performance of schools, of students in schools, of the ability of people to work, and I think also some long-term chronic diseases. And I think as that research develops, there'll be more and more clamor for indoor air quality, and we should certainly encourage that and make sure the research is done well and disseminated widely.
John, you'll have the last word of this whole thing. It needs to be, brightening our future.
Well, if there's a bright side of the pandemic, or among them was, I think, a rapid advance in understanding the transmission of respiratory pathogens, and really leading to knowledge about what to do. I mean, it's not that we don't have an understanding of what to do. We understand a lot. I think the challenge lies in implementation. The pandemic brought together the community of mechanical engineers, aerosol scientists, and health people in ways that were needed and that had not happened. If that collaboration continues and there's funding to support ongoing work, and I think then maybe we'll get somewhere. I will comment, ARPA-H has this initiative out that a number of groups around the country responded to develop enhanced sensors for pathogens, to think about how to control building operations to reduce risk. So I think there's an awareness, there's attention. I will say that if we learned some good things to do and then talk about implementation, then the challenge comes, because then we're talking about potentially millions of buildings where we might want to do some sort of upgrading, look at the ventilation system, install more sophisticated sensors. So we could be on the verge of a revolution if we get the right tools to do things, and people will do the implementation side. And that, David was sort of dwelling on a lot of the barriers that will inevitably come for that.
I like that. I mean, what we saw, and now I'm talking to our listeners, indoor air quality is an old history. I mean, we're thinking about it for a very long time, and we have historians that are working on it, etc. We had huge problem during the COVID-19 pandemic, but don't think that we didn't learn anything. We didn't get what we wanted, and the standards and better protection of the citizens, but we've learned a lot, and it's a long process, but we are better off today to improve our standards and improve the indoor air quality than we were before that pandemic. That would be my conclusion. Thank you very much, all of you. I mean, you were terrific, and thank you for your time.
Great. Thank you for the opportunity.
Yes, thank you so much.